are, my dear.
All right. Hello, friends. Welcome back. We are going to talk to a world famous, I'm going to say, obesity doctor. But I've known her for 24 years when we started college together at Emory. But she's come such a long way, and she's going to share so much information about what we all need to hear to improve our lives. I'm so excited for you all to meet her. Please introduce yourself.
Well, first of all, it is an absolute delight to be here with my dear college friend. I would guess we've given away our ages. So this was in 96 when we first met. And this is my first time actually seeing her in real life. I guess it's Zoom real life, since 2000, so 20 years ago. And it's amazing how time has passed. But I'll introduce myself to you guys. My name is Dr. Fatima Cody Stanford. I'm an obesity medicine physician and scientist. I guess you could also call me a policymaker, media personality, educator here at Massachusetts General Hospital and at Harvard Medical School. So in terms of my background, was born and raised in Atlanta, Georgia. Have done quite a few degrees in my life. I'm working on my 5th degree, what I'm calling my 5th and final degree. So did my master's in public health and health policy and management and finished that off, I guess, 19 years ago. Worked in public health. I've worked at the Centers for Disease Control and Prevention, the American Cancer Society. I worked at the Rape Crisis Center for 2 years, then began medical school. And went to medical school in Georgia at the Medical College of Georgia, then did a year of orthopedic surgery, because why not, in New York City. After that, I did residencies in internal medicine and pediatrics at the University of South Carolina School of Medicine, after which I came to Boston to do my 3-year obesity medicine and nutrition fellowship here at Mass General and Harvard Medical School. In my final year of that, I did my mid-career degree as a fellow in the Harvard Center for Public Leadership at the Harvard Kennedy School of Government, so my mid-career Master of Public Administration. And I'm currently working on my MBA. Why not? It's scheduled to finish May 11th, 2021. Not that I'm counting the days, but let's just say that we are
a lifelong student.
You're a lifelong student. So, as someone that's a pediatrician, someone that's an internist, meaning caring for adults, and someone who obviously spends a lot of my life caring for patients with overweight and obesity across the age spectrum, I'm dedicated to this work. Part of what brought me to this work was looking at some of the disparities in care that exist between racial and ethnic minority populations and majority populations with regards to the prevalence of overweight and obesity, particularly amongst Black women, which is the group that's most affected by overweight and obesity here in the United States. About 60% of African-American women or Black women in the United States have obesity, and another 20% have overweight, which means 80% of Black women in the United States have either overweight and obesity. And one of the key things I always like to start off with before I finish and let my dear friend here ask me whatever questions she's cooked up for me, is to really think about the language that we use when we're talking about patients that have this disease of obesity. It's important for us to just delete certain keywords from our vocabulary. One of them is obese. Obese is a label and it's stigmatizing. Obesity is a disease. And so much like patients can have diabetes or depression or anxiety or hypertension, which is high blood pressure, they have obesity, but they are not obese people, okay? Key thing. One other stigmatizing thing that we often do in medicine and what you hear in the lay population, especially in the midst of COVID-19, where obesity has really risen to the forefront of one of the major issues that really increases morbidity, which means sickness, and mortality, which means death, is this overlay of looking at morbid obesity, which I hate, absolutely hate. So let's get rid of that term. It's really severe obesity. Yes, patients that have severe obesity do have worsened outcomes, regardless of their racial or ethnic background and regardless of gender. With regards to COVID-19. And so that's important. I mean, but we could keep going on and on, but we really want to be respectful of either if you're working with, people and you see your family members struggling, you don't want to call them names. This actually leads to poor health outcomes. And so it's one of the things that I have spent my time changing even the language. I helped pass the bill or legislation at the American Medical Association on just the language that's used with regards to patients that struggle with excess weight. So let's be thoughtful, mindful about those things, and it affects how your friends and family will view interacting with you. If they have had this lifelong struggle with this, what we call chronic, relapsing, remitting, progressive disease of obesity. So I'll stop there and let you do your magic.
Well, you've been familiar with this field so much longer than I have. I just kind of started my journey into learning about nutrition probably a year or two ago. So I have so much to learn from you. But, I'm framing it from the standpoint of lifestyle medicine, where our focus is always patient empowerment. So what can we do to empower patients to take control of their life? So,
Yeah.
the 6 pillars, and I know you're going to go way more into this because you know more about it, but the 6 pillars of lifestyle medicine and just how we frame patient empowerment in dealing with excess weight. I like that term much better than obesity. But, sleep, of course, is super important. People ignore it, but it's a huge factor. I'd love for you to talk about that. And then nutrition and physical exercise, which are the commonly discussed ones. And then all the other ones and how they may impact, such as risky substances, alcohol, tobacco, stress, and then social connectedness. I know all the 6 pillars and much more, but what do you think is the most important of those, and how can we expand, and what teach us, enlighten us?
Yeah,
I'm
absolutely.
always ready to learn.
So I think the key thing is looking, the 6 pillars of, lifestyle medicine, is that all of them are important. And what I try to do is, we can think about all of them, but what we find with individuals is that we have to tailor our approach for individual people. I do want to go through kind of, some of the key things that you've brought up. So let's look at diet, for example. So, and when I talk about diet, we're talking about diet quality. So there are a few key things that I do with my patients when I'm looking at their nutritional status. Number one, I never, ever, ever have them report their calories. It means nothing to me. It's all about the quality of one's diet. But just because the quality of one's diet is ideal or optimal when we're looking at the composition, which would be like lean protein, whole grains, fruits, and vegetables, for example, as the predominant source, does not mean they'll be lean. They may still have severe obesity. How their brain decides to defend their set point for weight may be that making those modifications may not lead to any significant decline in weight, which is frustrating. So maybe some of the things I'm going to tell you will be frustrating, but they're the reality. We make assumptions about people that may have obesity, that they must be eating wrong or they must be doing something wrong. And maybe there are things that they may need assistance with. But when I talk to many of my patients, particularly since I only care for patients with overweight and obesity, many of them are actually quite stellar, but their brain has decided to defend a certain set point. So let's talk about the set point theory. Which is not really a theory. It really works. And I want you guys to think about your own selves, okay? Whether you're lean, whether you have obesity, whatever it might be, you might find that you're kind of in a certain weight range. Maybe the holidays come and maybe you gain a little bit of weight and then maybe kind of come back down, or maybe you're in this 10-pound range, but you might notice you yourself tend to be in a certain area, okay?
I'm the same from college, I think.
Yes. So it's just where your body decided it wants to be. So I tell that the way I like to simplify this is I want you to think of your body as like a gas tank, which may not be really attractive, but let's just think of it that way. So for those patients that have severe obesity, think of their bodies as like a kind of big army tank. Those big army tanks that kind of roll down the street, the big wheels that kind of like this with the missile that's shooting out. When you have severe obesity, I'm going to use a number, let's say 300 pounds. Let's say you weigh 300 pounds. Once you're there and you kind of maintain your weight there, your hypothalamus, which is part of your brain, decides that it wants to defend you at that level. So for many of you guys, you may remember the Biggest Loser study, where they put a lot of patients that had very severe obesity on a show and subjected them to all of these things, right? They were exercising 9 to 10 hours a day. They were, doing this significant caloric restriction. They were doing a lot of things, and many of them, to win this prize, this $250,000 or something like this prize, did all of these things to get down to a certain weight. And for most people, unless there's certain deficits in the brain, which we won't go to, but there's certain deficits that will not, no matter what you do, you don't lose weight. But for most, they will lose acutely. I don't care about acute weight loss. I care about sustained weight loss. I want to know, where are you going to be in 10 years, 20 years, 30 years, 40 years, not what you were able to do in the first 10 months, if that's not sustainable. So what happened after that study, and actually this study was done by a colleague of mine, Kevin Hall at the NIH, where he actually studied the Biggest Loser contestants.
Mm-hmm.
And this is a unique group, right? Because we know who goes through that level of rigor with regards to the activity. And so I'm going to pose a question to your host today, and ask you, what do you think the percentage was of individuals that regained all of their weight?
Well, based on your set point conversation, probably 60 to 80%.
96%. So
Wow.
96. So what happens is their brains were here. They had this gas tank that the body wants to get back to where it wants to be. So it's going to fill the gas tank however it needs to do. So what happened after those contestants went on the show, they typically had a resting metabolic rate. So that's how much your body burns, right? Of somewhere between 3,000 to 3,500 calories. So that means if they did nothing, that was just about how much their body would burn. After the show, on average, their resting metabolic rate was between 700 and 800 calories. All right, so that means if they ate either somewhere between 700 to 800 or more, their body's going to completely shift up. Now, it's not as simple as that. It's actually even more complex. There are actual hormones that actually change within the body to bring you back. And so it's this tug of war. So you may say, oh, and my patients come in and they say, oh, I was successful. I lost 100 pounds, but now they're 102 pounds. And up from where they started. So they actually have a net gain of 2 pounds, right? That's because the brain went back. It knew what to do to compensate for in the body to fill the gas tank back up. The same is also true for those that are lean. So their patient, the person I would think of is someone like a Kevin Hart, the comedian, right? He's really a little kind of person. And I've seen him in real life, like, right. He makes me feel like really ginormous, and I'm only 5'6". So maybe I do have on heels, but he has a gas tank that's like the size of one of those little smart cars, the little smart cars that are like really compact. And so even if he tried to push his gas tank up to maybe just a mid-size sedan, it probably won't work. Well, not probably, let's just say it won't work because it's just not within where his brain thinks it should be, right? I think this kind of dichotomy between like The Rock, which they usually pair with him, kind of shows that difference, right? The Rock is never going to be a Kevin Hart, and Kevin Hart's never going to be The Rock. They're just not made that way. And so it's frustrating because you're like, okay, if you're little, some of the little people were like, I want to be bigger. And then the bigger people, I want to be little. And the body is just like, no. So the reason why this is important is that if you've struggled with weight, don't feel defeated. Just recognize that that's what the body wants to do. We'll come to how we change that point later, if and then those things haven't worked. So we talked about
the next question.
Yeah, well, we'll come to that.
Even so for myself, activity, how do I change it?
Yeah, how do you change this way? We'll come to that. I won't forget, I promise. When we look at physical activity, we often also sell the wrong message with regards to physical activity. It's great. It does a lot of great things. It helps improve stress. It alleviates depression, anxiety, at least temporarily, right? It can improve our blood pressure. It can improve our cholesterol readings. It can do all these great things. On average, though, if we were to hold everything constant and look at what the role physical activity actually plays in our weight regulation, it actually typically causes weight stability. Okay, but a lot of people go and join gyms. Well, maybe not during COVID, but outside of COVID, join gyms. They do all these things to lose weight, and they go to the gym and they go really hard. And then they get, like, let's say they go hard for a month, whatever that hard looks like to them, because that's going to look different for different people. And then they get frustrated because they look at the scale and the scale is whatever that number is, or maybe like within 2 pounds or something. And they're like, are you serious? I've been doing this hour. I don't understand. Like, remember that set point. Set point's important. But now this is interesting. Over our adult lives, we tend to have a gradual increase in weight over our adult lives. Once we get to about 65, we stabilize, and then our weight begins to go down. My 65 plus group, and I have quite a few of them, they think it's exciting, but no, it's not really that great. When their weight starts to go down, it's because they're losing muscle mass. Okay, so it's not that they're like all of a sudden really successful with their weight loss efforts. They are losing the things that we want them to keep, but that's just what happens to the body as it ages. So the message I think the sell with physical activity is that it gives you all of these benefits. But the benefits that most people presume it will give them is that will cause significant weight loss. Now, people try to challenge me on that. Like, I lost such and such. Yes, there's a small minority of individuals that can change major diet modifications and have significant weight loss and maintain it. There's another small minority that may change physical activity and have significant weight loss. But for most people, they may notice, they do things and they don't go up, they don't go down, but they kind of just remain stable. So that's super important. Sleep quality and duration plays a large role in how the body regulates weight. And so I do ask my patients about their sleep quality and try to figure out how we can maximize their sleep quality. There are pathways in the brain that regulate weight that also are kind of really working with pathways of the brain that regulate sleep. And when we throw one of them off, it can affect how our body decides to store. So there are two primary pathways in the brain, one that makes us lose weight, one that makes us store weight. And when we throw off the sleep part of it, or if we're like night shift workers, like if you guys work the night shift or something like that, you may notice, wow, my weight went up. I don't get it. I haven't doing anything any differently. It's because the brain is unhappy with you. It wants to be asleep when it's, during the nighttime, and it wants to be awake when it's daytime, like, you see here to my right. When we flip the nail on this head, for most individuals, now notice nothing's 100%. For most individuals, they will gain weight. And so if you look at something like the Nurses' Health Study and you compare nurses that started working in their 20s at the same time, the night shift nurses versus the day shift nurses, there is a significant difference between them 10, 15, 20 years later in terms of their weight status, because their brain is not happy with them. And so for some patients, the key thing I might do is try to see if they can get shifted back to a daytime shift. And that in and of itself may be enough to shift their weight, not maybe all the way down, but, cause some major changes. I can't remember what else you asked me about. Those are some of the—
Let's talk about sleep for just a minute.
Okay, yeah.
In lifestyle medicine, they talk about getting, 8 hours of sleep. And my set, I don't know if there is a sleep set point. I'm making that up.
Yeah, I think
there probably is. But
and we don't call it that, but let's coin it now. Let's make it the Shilpi and Fatima sleep set point theory.
I try to get 8 hours, but if I get more than about 6.5, I'm really tired.
No, I'm like that, Shilpi. So you and I are
like my ideal set point of sleep. And if I get 8, I'm exhausted. If I get 5, I'm okay, but I mean, 6.5.
Not as ideal, right? You're like me.
So you tell me about sleep set point, because we're coining it now. Do you know?
Yeah, we're coining.
I haven't read about this. It's just a thought that popped into my mind because of the diet and the weight set point, and so.
Yeah. So on average, most people do fall in that 7 to 8 hour range. But if you actually look at the National Sleep Foundation and look at the sleep charts, our amount of sleep that we need really varies based upon our age. So what you'll notice is that early in life, if you're looking at your little ones, for example, you may notice like when they're young, they sleep for like freaking 18 hours, which is great for you because you get some work done. But as they begin to age, right, they will require more wakeful time, and then when we get to like where we are in our 40s, we're kind of typically in this range of 7 to 8 hours. But let's go to what you said. You're like, hey, around 6.5, that's kind of that's where I feel is my sweet point. It's important with everything that I'm saying that you tailor it to fit you. It's about being your best you. So I cannot at any time ever sleep 6 hours or longer. Like I can sleep 6, but I can't, like my body just will not do it. I've tried it on vacation. I've tried it, but it just doesn't do it. It will wake up. And I don't feel sleepy. Like I'm not one of those people. I mean, look at me now. I mean, I'm pretty alert, right? I've just seen, I don't know how many patients this morning since 8 a.m. But I'm not tired. I don't feel tired at all. I mean, I will start feeling tired like in the evening time, like 9, 10 o'clock, that's when I'll typically feel tired, which is, I think, appropriate. Although I still don't go to sleep. I'm still working, but that's another story for another day. So I do think that people have this range of like, what is their sweet spot. As we age, believe it or not, once we get into our 60s, 70s, we actually require a lot less sleep, which doesn't really make sense. You would think that it would, like everything else in life, it kind of goes back to where you were at the beginning of life, right? But with regards to sleep, you'll talk to people, my patients that are in their 70s and 80s, and they're like, yeah, I slept for 4 hours, and they seem fine. That's probably on the low end. Maybe it is more like a 6 hour type range, but people listen to their bodies. And so with regards to any of these things, your diet quality, your activity, it's about finding your soulmate diet, your soulmate workout, your soulmate sleep patterns, whatever that is. And everybody differs, and it's okay that we are different. Just learn what works for you and do it every day.
I mean, this gets into so many other thoughts
Yeah.
that I have, especially since I'm
Yeah.
an ophthalmologist, and I have patients who literally sleep from 9 a.m.
Mhm.
to 12 p.m. by choice,
Oh,
or
really?
because they can't fall asleep all night. And then I have patients who sleep from 11 p.m. to 1 a.m. and they come in with, progressively worsening glaucoma. And I don't
Mm.
think I've actually ever thought about it before just now. Like, could their
Wow.
glaucoma progression be due to their
Yes.
lack of sleep? We know it's associated with sleep apnea. So we
Mhm.
won't get into eye things too
Maybe
much,
there's a
but it's
study,
so
buddy.
interesting.
I'm a physician scientist. This isn't per se my area of study. I would have to throw something with regards to obesity in there for it to make sense for me. But
Right. But I mean,
um,
and
it's interesting. Actually, I was just talking with one of our sleep physician scientists here at Mass General just yesterday, and she was like, "Oh, I have the sleep lab, and we can do this, and we do this." She's like, "What do you want to study?" And I was like, I don't know. I mean, I could add sleep to everything, but maybe it is looking at the progression of diseases like glaucoma or other chronic diseases, um, tied in with timing of sleep, timing, duration, and quality of sleep, right? Um, so I think that'd be interesting. I don't know. This sounds interesting. That sounds definitely opto. This would be one of those papers I'd be like, you got to throw me on one of those, and I'd help guide the obesity side of things.
well, I'm in
Um,
private practice, so I don't really
yeah,
get to
no,
do
I'm
a
not
lot of
saying.
research, but it's
No,
so
no, no.
cool and
That's
so
what I do.
interesting.
That's what I do. I'm always doing like 20 papers at the same time. So
That's great.
I have to
Well,
think. I
we'll
have to
look to
think of
you for
my
the future.
students that are students, residents, or fellows that may need projects. Actually, I have one. I think I have one that may do some
Well,
work here. I'll call her up after this. They'll be like, oh gosh, there's more work. But yeah, these are all interrelated. I think Shelby, you bring up an extremely important point about how the body is completely interconnected. We often, especially as doctors, we will look at one thing. What I love about obesity medicine is that when I'm treating your obesity, and if we're able to achieve success in that treatment, I'm able to delete problems off of your medical list. There is no area of medicine where you can do that. So there are often times when I have nothing left to bill for to get paid for the visit. So I've learned how to do that also. So then if you put history of obesity, that counts. History of diabetes, that counts. There's actually coding that allows me to capture the fact that my patients improve so dramatically that I have nothing left on their problem list. It's rewarding for me as a doctor, who I call myself to them their coach, right? I'm the coach, they're the star player. If they don't show up, I can't do the coaching. Yes, I'm important, I think, but the players on the team are more important. They're who win the game, and they're the star player in the game of life, right? So that's how I think about it. And so that dynamic that I think is created between a doctor and a patient, particularly my patients, I think of me as their family. And we have strong connections, and that goes with people that look like me, people that don't look like me, that you would not think would be typically people that want to tell me whatever is going on. Because I think when we're looking at weight status, it's so tied into one of the things you brought up, which is stress. And I did a whole hour-long lecture on stress and obesity last Friday, so we won't do that. But it's important to recognize that when you are exposed to stress, whether that's stress in the form of financial stress, or stress in the form of racism, that it actually increases inflammation in the body. And when that inflammation is increased, we have a deposition of adipose, or fat tissue, that likes to go to one main area, our central region, which is our stomach. And when it's in that area, that's when it causes all kinds of problems. It leads to diabetes, it leads to fatty liver disease. If you guys can think of a piece of chicken liver in the store, it looks nice and kind of smooth, right? But when we have fat around it, our livers love fat, so it likes to take it in. So it ends up looking like a marbleized piece of steak, where you see the fat strands. And that's not good. It's actually becoming the number one reason for liver transplants here in the United States. And I see it in as young as 3 years old. So it's something that we can't discount. And the best treatment is pretty substantial weight reduction. Surgery is by far the best treatment of fatty liver disease in terms of the resolution for those that have severe obesity. But that's, that's only for those
Surgery, you're
that need
talking bariatric surgery?
bariatric surgery.
Okay.
So it's the most effective in actually treating not only fatty liver, but, more advanced fatty liver. So NASH, right? So non-alcoholic steatohepatitis. But
So I want
yes,
to go back to two things that you said. One,
absolutely,
the reversal of disease. That's one reason I fell in love with lifestyle medicine, is the fact that we have evidence-based medicine or science showing that we can reverse disease like
absolutely.
diabetes,
Isn't it
like
great?
heart disease, which is so wonderful. I mean, we weren't taught that in medical school. I wasn't, at least. Maybe you were. Like,
No, I wasn't.
when I graduated, I never knew you could reverse diabetes,
Right.
heart disease, and the fact that we can is so empowering.
Right. It is, absolutely. No, I think that's really key. I mean, I think the key tools, though, a lot of tools that, expand beyond the lifestyle medicine realm. The thing that reverses diabetes the quickest is surgical intervention. So within 5 days of bariatric surgery, 80% of people resolve their diabetes, which is unheard of, because in 5 days, very little weight loss has occurred. We don't completely understand why it's as potent as it is. For many of my older patients that I send to surgery, and yes, I do send patients in their 70s to surgery, I tell them, because they've been on hundreds of units of insulin, a day, and I tell them, I doubt that they'll come off of their insulin, but there'll be a significant reduction. And almost everyone that I've told that has completely come off of their insulin that they've been on for 30 to 35 years. The thing for my older patients, that have severe obesity, is that they just wish they had done it 30 years earlier. I'm not super great in terms of getting them 30 years of life back, but I can help whatever life they have left to be the best that it is. And it's just amazing to see how their life shifts, and how they wish that they were able to go back and think about, like, their time with their kids, not only now their grandkids or great grandkids, that they're able to do things and may not quite still have the agility, right, that they would have had in their 30s or 40s, but have more agility now than they did then because of the degree of excess weight.
So let's go back to diet, or unless you want to finish the 6 pillars and then go back to diet, the other 2.
Whatever you want. I'm going to let you draw the show, my dear.
Those 2, and then we'll go back to diet, because
So which ones are left? Because I use it.
2 were avoidance of risky substances like
Mhm.
smoking and alcohol, and I'm sure those have a lot of impact on sleep and obesity, and then the social connectedness, and that probably relates to stress and all of that. So I'll let you.
So the avoidance, and so the this is going to sound bad, but so I don't like for patients to either drink and or smoke, although patients do. For smoking, however, many people want to continue smoking because it controls weight. Nicotine can lead to, weight loss or weight stability. And then when they come off, so one of the key questions I ask at an initial visit is that, did you stop smoking, and how much weight did you gain when you stopped smoking? So there are a lot of people that continue smoking. If you go to Europe right now, I don't know what's going on with COVID, but when I go and give lectures in Europe, like, everybody's smoking. I come give a lecture, maybe I'm doing a whole workshop series. They go out, they smoke, they come back, and they tend to be leaner, but that's not the way we want to control or regulate weight. So obviously tobacco is bad for us. In case you guys didn't know that, that's a memo for today. Tobacco is bad for us. And I'm someone that does not drink alcohol at all. So I tend to be maybe a little less empathetic for people that struggle with right. Yeah, I'm just saying, but my patients, right? So also when they tell me, oh, I drink this, I'm like, okay, I have no idea what it is. But I mean, I get a sense of, like, what it's called. And I'm like, what is that? So I have to ask them. But, the goal is, to get them feeling normal without having to have additional substances. And then when we go to connectedness, when we're looking at weight and weight regulation, often it's having a strong support system. So I take care of multi-generations in my practice. I may be taking care of the children, the parents, and the grandparents. And I may be using different strategies to help regulate their weight, but the messaging is the same, right? The messaging of what I'm teaching, what I'm telling them, and then they can support each other. There's some families where I'm taking care of 6 family members. The 3-year-old little girl that I saw as my first patient yesterday, now I'm going to be taking care of both parents. And what I use for them will likely be significantly different than I use for her, but hearing that similar messaging, getting that similar thought process into the family really helps them support each other outside of the time, the minuscule amount of time they spend with me, working with me and their care. So super important, I think, is to have that connectedness and have that support. People often feel isolated, especially people that have obesity, and they've often received a lot of really negative talk from physicians and other healthcare providers about what they didn't do well. And my goal is to empower them, to give them back their power and recognize that, I'm here to help you be your best self. We're going to use whatever strategies that takes over the long term to do that. And that I'm your ally. I think that's the key thing.
So for patients like around the world, just I wanted to touch on two things that you said, but one thought was, I mean, should they, if they have a diagnosis of obesity or excess weight, should they be looking for an obesity medicine doctor? Because I know there's more and more of obesity trained doctors now.
Yeah, there are. So in the United States, I can speak a little bit better to what we're doing in the US, although I guess I'm giving a lot of international lectures. So maybe I could talk about whatever respective country you want to ask about. But here in the United States, there is the American Board of Obesity Medicine, and you can go and look in your area, look on their website and find physicians that are credentialed in your specific area by zip code. So if you live in zip code 12345, I don't even know if that's a real thing, you can look and see who's actually certified in your area. There are differences when you look across the obesity medicine doctors, although I have a paper that just is coming out, I think any day now, that's been accepted for publication. Will I think probably be available in the next week or two, where we looked at those that are certified in obesity medicine and whether or not they deliver a high level of care regarding obesity. And we did find that they do typically provide care that meets the guidelines that are put out with regards to obesity. So I would say that you're going to get a solid likelihood that you'll get people that are skilled in the space. Now, someone like myself who's done 3 years of fellowship training versus most who've just taken classes taught by me and enough to get enough credits to sit for the exam, where there's going to be a bit different. So if you want, it is hard to, there's only about 50 of us that are fellowship trained in the country, a little over 4,000 that are now board certified. So there are differences, in those groups, but I would say that in general, our goals are to support those that have obesity. And in the best way that we can. And so my goal is to also continue teaching those that have been certified. And that's why I do as many lectures as I do for those people that are really into like optimizing their care. If I can give a lecture and people take a few key pearls to adopt in their patient population, they may not be getting exactly what I would be able to deliver, but now they have some additional tools that they may not have thought about. And so if you're still struggling and you're like, my gosh, I've been trying this, I've really maximized my lifestyle and I'm still having issues, that's definitely when you want to bring in someone like myself or some of my colleagues that are obesity medicine physicians. You don't have to immediately, just because you have obesity, go to an obesity medicine doctor. I think that's an important point to get across. Also, so it's typically those patients that have done what they could, still are struggling, and then need some additional tools, whatever they may be. And they may still fall under, I always will maximize lifestyle first before graduating therapy to medication, before graduating to surgery, or using a combination of those different modalities. And so, as you can tell, you keep hearing me say I tailor it to fit the patient. And patients always ask me, well, what am I gonna do? And I'm like, look, calm down. Your body gives me the answers, and I have to listen to your body. I know how these things work in theory, and I know how they work in humans, but I don't know how they work in your vessel, and your vessel is responding differently to the outside environment than someone else. Unless you're an identical twin, I would anticipate that you would respond differently even from your siblings. And I do take care of I take care of one family, I take care of 3 sisters, and they all have very different responses to the exact same treatment. And of course they want whatever the other one got because this person did this. Don't compare yourself even to your own family. Compare yourself to yourself. The only person that counts, and I tell the patients when they're in the room, which is now via Zoom, the only person that really counts in the room at that moment is them. It's not them or the patient that's coming behind them or the patient that was in front of them. It's them. And so I have to tailor to fit them.
I love individualized medicine. So
Yeah,
now, if you have time, there's
I
like
do. Mhm.
one thing that you said a 3-year-old. So I wanted to highlight kind of this generation of children that's obese, and then go
They
back
have
to whole food,
obesity.
plant-based diets and how we can change that set point that we mentioned
Mhm.
earlier. And
Yeah,
those are my last two. Actually, I have one more, if you have time, is
yeah.
walk us through a day in the life of Dr. Stanford, like
Oh, that would change every day, but that'd be interesting.
and like diet and what you do, if you have time
Okay.
for all of that.
Yeah, no, absolutely. Let's go with a key point that I haven't brought up in this particular talk that I think is important for me to get across when we talk about the 3-year-old or my really young patients. And that key thing is that weight is more heritable than height. Okay, so I always like to repeat that again because it sounds a little funny when I say it the first time. Weight is more heritable than height. So when we think of parents and we think of patients that have tall parents, we are like, oh my gosh, they're going to have tall kids. Or if their parents are short, oh, they're going to probably be short, right? Like if we, that's just kind of how it goes. We don't recognize that weight is by far a much highly heritable trait than height. So when we're looking at children, especially children with early onset obesity, which is between those ages of 2 and 5, so I'm putting on my pediatric hat now, the likely reason they have obesity is not what you fed or didn't feed them. It's because they came probably from parents that had obesity. Okay. The likelihood that kids will have obesity when their parents have obesity is on the order of 50 to 85% likelihood, even if you do all the right things. The American Academy of Pediatrics says what, breastfeed for the first 6 months of life at least, maybe the first year if you can, do all of these things. And so a lot of these parents, including the 3-year-old that I saw yesterday morning, she only drinks water, and her mom gives her, Crystal Light, so she never has any sugar sweetened beverages. And then she makes sure that she purees her food, and then she buys only Whole Foods, literally from Whole Foods. She does all these different things. She doesn't, she looks at the price, she makes sure nothing's processed. She does all this thing, but her kid is 3 years old and weighs 73 pounds. So when I then focus on the parents, because I can put on my adult hat too, it's delightful. And I asked mom about her weight status, and I asked dad about his weight status. Actually, mom was the only one present during this visit, but the dad, she was able to give me that information. When I calculate BMI, and BMI is not perfect, you guys, it's not the end all be all, and that's another story for another day, but they both had severe obesity. So I'm looking at people, so severe obesity is categorized, if you're looking at the BMI scale, as body mass index greater than or equal to 40, and both of them have it. So when I'm seeing a 3-year-old that has severe obesity and both parents have severe obesity, I'm not at all shocked by this, the vessel by which they came through. So this idea of fetal programming, which is extremely important, which is if a mom goes into pregnancy with overweight and obesity, she has increased inflammation. We talked about inflammation and stress. It's not just the stress externally, it's actually internally. And what that leads to is lipid exposure, which means cholesterol exposure to the fetus, and actually an uptake in cholesterol in the body. That leads to kids having things like obesity and fatty liver and diabetes and things of that sort. So you might be like, okay, well, so then how do we modify it? The best study that was ever done was actually a study looking at children born to mom and dad, same mom and dad, okay? But before mom had a surgical intervention, particularly bariatric surgery, and then they followed 20 years later and looked at the kids born after the mom had surgery. It's important to note for those that are listening that if you happen to have surgery, many patients still have obesity, just not the same severity of their obesity. So it's important to note. When you compare the children that were born before and after the mom had surgery, so same parents, there was a 3-fold decrease in severe obesity in those kids. There was an 8-fold decrease in macrosomia. And for you guys, I'm using some fancy words, but macrosomia means being kind of born with a big baby, 10 plus pounds, something like this. But an 8-fold decrease. Completely improved lipid profile, which is cholesterol values, completely improved insulin and glucose and hormones like ghrelin and leptin, these hormones, which we consider to be hunger hormones and things of that sort. We didn't change the genetics, right? The genetics are still mom and dad. These are still the same 2 parents. But what we have changed is the mom's intrauterine environment. Now, people always ask me, so what about the dad? Does the dad not have anything to do? We don't have that great long-term study looking at dad, but there have been studies that have looked at the sperm of men pre and post surgery, for example, and we see the epigenetic labeling on the sperm changes drastically 1 year post surgery. Now, we haven't followed those kids for 20 years to see that study that I was able to compare and contrast. But I think that's extremely important to recognize that we can modify the health of children before they're conceived. And that's actually the best time to intervene, because once they get here, they already came through that vessel and they're already here. So when people come into me, many women that may struggle with infertility, particularly associated with their obesity, they come in looking to, obviously ultimately get pregnant, but they just want to focus on just like kind of short-term solutions. My thing is, let's do something that has a better overall success profile that will help not only you, but help your offspring. And when I frame it in that way, then it's like, oh, okay, well, I had not thought of it that way, because often as women, we will put others before ourselves, even children that have not yet to be conceived. So I don't know, I was supposed to answer some other questions, but I got really excited into that realm of things.
I love it. I think
yeah.
it's so important. And
yeah.
I also want to highlight, and I'm sure you say this to your patients, that even though you were born with those genetics or epigenetics, we can still make a difference.
We can still make a difference, unless you have those. There are a few situations where that actually I can't, but they're limited. So people that have, I'm going to throw out some fancy words, melanocortin 4 receptor mutations in their homozygotes, where there's nothing we can do to treat them. They are very rare. There's only 20 case reports in the United States. I have one patient that does meet that criteria. There are a few only other issues where it's like 1 in 20, in the entire world that we've ever seen. So it's very rare that we're not able to make a difference, like a 0.0000001% likelihood that we can't make some difference. And the degree of difference, differs, but it's also why I don't ever give my patients a target weight ever. I care about like trends, like what have they like lost, how have they sustained it, but I never give them a number. I don't let them tell me a number either, because let's say they want to lose 100 pounds. Let's say the number they come in with, and let's say they lose 92 pounds. Let's just say they're never going to feel satisfied that they didn't reach the 100. We might say that, you would say, wow, that's amazing. You lost 92 pounds. You've maintained 92 pounds, but they are still thinking about that additional 8 pounds. Why you should never set an actual number. Pay attention to how you feel and how this can be sustained. Not acute weight loss I care about. Sustainability is key.
So that's perfect into the next topic that I had mentioned, was the whole food plant-based diet. So everything in lifestyle medicine is trying to get away from animal protein, more to plant-based protein, and more to whole foods, not processed foods. I know you're all about that. So, and how do you incorporate that into your diet? Do you recommend people move away from animal protein? What are your thoughts?
So I think, it's interesting, because if you look at myself and my sister, and I'll just use, I do still eat poultry and seafood. I've never had pork ever in my life, and I haven't had beef since 2000, so 20 years ago. My sister's vegan, and she feels much better as a vegan than she felt as a vegetarian, as she felt as more of a pescatarian. And, I think it's about finding what works for people. I do agree that, having, those like meatless Mondays or whatever it might be, are really great things. It's great for our environment as we look at climate change, which is real, you guys. It's real. I don't know there's some science people that aren't really listening to science, but it is a real thing. So it's better for our environment. It's definitely better for our bodies. But some people feel not so great in a vegan style diet or a vegetarian style diet. And so it goes back to listening to your individual body. I had a 71-year-old patient that I saw today who's adorable. We had a lot of political discourse today. But in addition to that, for her, she feels better when she is eating more beef and more like fungi, i.e. mushrooms and things of this sort. And as I have to let her listen to her body. I mean, her weights responded very nicely. But I have to listen to what does she say? What do her labs look like? Her labs look great. So, I think it becomes individualized. I think overall, definitely the key thing I definitely always support is the less processed, the better. So that we've talked about. And so I completely agree with that. And I think, like I said, for many people going, the more plant-based you can be, overall, the better. But that some people feel really not so great, and, if they go kind of all the way to that end of the spectrum. So it just depends. And what I do when have my dietitians working with patients is to work where they are. Some of my dietitians are vegan, and so, we'll can really kind of guide you in that direction. Some aren't. And so, but they can guide you in whatever direction. And so I have it tailored, like I said, to fit the patient, and whatever their, not only their preferences are in terms of whether it's, pescatarian versus vegetarian versus vegan, for example, but also like the cultural appropriateness. Like, are they Indian like yourself, and do they prefer, more lentils and different things of that sort, eggplant, right? That's what, a lot of the Indian diet, and making sure that it's tailored to fit that, so hopefully that gives you some answer there.
Well, I am vegan now, except
Oh, you are?
I take fish oil daily to help
For the B12s? Yeah.
And I take it to help my HDL too. But
yeah.
other than that, I'm vegan.
Okay. So you're like my sister.
And and in bread, I'll if bread has eggs baked into it, then I'll still eat it because I'm gluten free too, and I rarely eat bread. So, but anyway, so I feel much better, and I can share my stories. People who are watching this have already heard my stories, so I won't share too much.
Yeah.
It definitely takes time to transition to a vegan diet, but it feels so much better. But Whole Foods is it's so important. People get caught up on the expense. They're like, oh, it's so expensive to be.
It's actually cheaper.
And it's so exactly. So
it's actually cheaper because the vegetable, like if it's mostly vegetable based, or even if you're using beans and all of these things are much cheaper than a lot of the processed things. If you're kind of, shopping the perimeter, right, of the grocery store, that's typically better. There are all these services, like I use Misfits, for example, which delivers that whole box of organic vegetables, every week. Is delightful. Sometimes at first when they did it, you didn't know what you were getting. So that was a little disturbing, because you're like, what am I getting? And then sometimes you're like, I don't think I know what this vegetable is. And so I go look it up on Google and be like, now you do get a chance to pick, and they actually tell you, oh, okay, this is this. And I'm like, oh, I didn't know that existed, but here it is. So I think, being, you want a colorful diet and not just jelly beans, you guys. You want a colorful diet with actually fruits and vegetables, I think is key.
I hear my baby who walked in.
Oh no, you should go. So I have a meeting in 2 minutes. 2 minutes.
I love this. I'm so happy that you were able to join us. I love saying that Whole Foods, plant-based diets can be cheaper. And you don't have to spend money. You don't want to buy those processed vegan foods. I love all the work you're doing. We're going to learn so much from all your research, and oh, that's great. For so long, but so thank you so much. I so appreciate it. I will send you a copy of this, and
please do
more. You can learn more, and we'll put links to Dr. Stafford's information and other obesity medicine resources.
Okay, thank you. Excellent. Well, yes, it has been a delight being here. Thanks so much for having me, Shilpi. It has just been great seeing you after 20 years. I think it's actually 20 plus because we graduated in May of 2000. So it's been a delight. Thanks for having me. And I'm hoping that, those that listened gained some new insights into things that maybe they've been challenged with.
Thank you.